Good morning, everybody. My name is Claire Smith. I'm a physiotherapist and a research coordinator at the University of Calgary. My co-chair moderator is Diana Cerna. She's an RT by training and also a research coordinator, and you can see all her letters after her name up on the screen. We'd like to welcome everybody to this PTRT Research Year in Review. Hopefully, you'll all be interested in the presenters we have picked. We've got some excellent presentations. They're going to have 15-minute presentations and then 5 minutes for questions.
Thank you once again for being here with us this morning. Please help me in welcoming our first speaker to the platform. This is Najla Al-Atabi, a distinguished scholar from Saudi Arabia. She is sponsored by her government and pursuing her PhD in rehabilitation science at the University of Alabama in Birmingham. Her impressive academic journey includes a master's degree from the University of Wisconsin River Falls and a bachelor's degree from Taif University. With a deep passion for understanding the impact of physical training on the cardiovascular and respiratory systems, Najla's dissertation delves into exercise training and testing for individuals with cystic fibrosis. Today, she's going to present her abstract, methodological, I knew that word would get me, quality and ICF-based outcome measures utilized in exercise interventions for people with CF, a systematic review. So let's give a warm welcome to Najla.
Thank you, Diana. And it's a pleasure to be here, and thank you for having me at this great conference. So our study is a systematic review of the methodological quality and outcome measures utilized in exercise interventions for individuals with cystic fibrosis. So to start, there are no relationships to disclose related to this presentation. So here is an overview of my presentation today. So first, I will talk about the background of the disease. Then I will discuss the research problem. And after that, I will introduce the purpose of the study. And then I will move to the method section. After that, I will spend more time on the results. And after that, I will discuss our finding and address the implication of the study. So cystic fibrosis is a genetic disease that affects multiple systems, including pulmonary, digestive, and reproductive system. And most of the common symptoms in people with cystic fibrosis can include poor growth, thickness mucus, shortness of breath, and skeletal muscle dysfunction. And you're gonna see once we get to the results why I focus on these symptoms. So here are some statistics about the disease. So there are about 90,000 cases of CF reported worldwide. And these cases are reported from about 43 countries. And almost half of this number is reported in the United States. And also it's estimated that around 10 million people carry the CF gene. So one of the therapeutic agents used to manage the disease is exercise, as it can enhance aerobic capacity, exercise tolerance function, quality of life, cardiovascular functions, and it can also increase or at least maintain pulmonary functions. So in CF, we can use the International Classification of Functioning, Health and Disability model to implement and plan physical activity programs tailored to individual needs. And the ICF model is a well-accepted framework, and the standard language of the ICF can provide a structural definition and assessment of health and disability. So the ICF model consists of 4 domains: body functions, environmental factors, body structures, activities, and participations. Under each one of these domains, there are multiple chapters, and these chapters are diverged into many codes. And each code is combined of letters and numbers, and the letters are 4, and they represent the 4 domains, as you can see here. And the codes are coded in a numerical order and in different level. So the description of the ICF category becomes more clear and specific as the level increases. So another thing, the ICF is crucial for evaluating the assessment of functioning, which can be explored at an individual and instrumental level. So to the best of our knowledge, no reviews have explored the outcome measures of exercise interventions in cystic fibrosis in relation to the ICF model. So this was our first aim, is to link the outcome measures of exercise studies in CF to the ICF model. And our second aim was to examine the methodological qualities of these studies. So for the methods, we did a comprehensive search on exercise and cystic fibrosis, and we extract the outcome measures and link them to the ICF model. And for the equality, we scored the quality using 2 different tools. The first one was the Effective Public Health Project, which also known as the Quality Assessment Tool, and the other one, Physiotherapy Evidence Database. And we also used the Modified Sackett's level of evidence. So for linking the outcome measures, we followed the ICF linking rules, and here are some of the rules. So linking the outcome measures should be appropriate and specific to the most accurate ICF category, and we should appropriately use the code, the category specified or unspecified properly, and also the challenging outcome measures or the outcomes measures that are not identified or coded within the ICF can be coded as not coded or not covered, not coded or not identified. So for our inclusion criteria, we included any type of exercise intervention that specified frequency, mode, and duration, lasted for 1 week or longer, and had pre and post measurements. And here are the databases we used and the main key terms we used for our search. So we found about 4,800 articles after removing the duplicates and irrelevant studies. From the abstract screening, we found 166 articles. After doing the full text screening, only 89 studies were eligible for our review. So for the results of the 89 studies, 35% were randomized control trials, 7% were clinical trials, 12% were 2-group pre-post design, 40% were 1-group pre-post design, and 5% were either case series or case reports. So this exercise, the most used exercise was aerobic activities, followed by resistance training and respiratory exercise. And the duration of the studies ranged between 1 week to 3 years. And for the sessions, they ranged between 2 to 7 sessions per week, and they in general lasted between 45 minutes to 1 hour. And the sets for the resistance exercise was between 1 to 2 sets of 8 to 12 repetitions. So for our outcome measures, when we link them to the ICF categories, we found that 71% were linked to the body function, followed by activity and participation, which was 22%, and only 2% for body structure, and the environmental factors were less than 1%. Others here, 4%, and they are either not coded or not identified. And for the personal factors, 1%. And here are more details about the ICF categories. And this table shows the ICF categories at the body function level. So it's not surprising to see that the most targeted ICF category was respiratory function, followed by exercise tolerance function, and energy and drive functions. For activities and participation, the most addressed ICF category was carrying out daily routine. And for the body structure, the most targeted ICF category was the structure of the trunk. So using the quality assessment tool, we found that 23% of our study were high, 52 were moderate, and 25 were ranked as low. For the Bedro score, the scoring ranged between 3 to 8, and the median was 6. And for the level of evidence, only 21 studies were ranked as level 1. So for the discussion, our findings shows that in terms of the ICF model, most of the outcome measures were targeting the body function domain. And this is also is consistent with other research in the literature. According to a Cochrane review, in CF, most of the outcome measures were also addressing body function. However, this review did not use the ICF language. We found other reviews that used the ICF language. However, these reviews were in different populations. So based on this review, the most targeted ICF domain was body function, which is consistent with our results. And since cystic fibrosis, in cystic fibrosis, the most affected system is pulmonary system, we compared our results to the ICF corsets for obstructive pulmonary disease. And we found that the most common ICF categories based on these corsets: respiratory function, exercise tolerance function, muscle power functions. And these also are consistent with our results. So for activities and participation, the most frequently targeted ICF category was carrying out daily routine. And this is because frequent studies used cystic fibrosis health-related quality of life questionnaire and physical activity questionnaire. The most frequently used questionnaire was cystic fibrosis health-related quality of life. So for the body structure, the most targeted one was structure of the trunk, and this code covers bone mineral density and postural evaluation of trunk and chest. For the environmental factor, the most targeted ICF categories were individual attitudes of immediate family members and societal attitudes. However, these categories were addressed by only 1 or 2 studies. And this is important because shedding light on in environmental factor is important because the impact of exercise on body function can also be affected by the environmental factors such as climate and availability of exercise equipment. However, these outcome measures were not addressed by any of our studies. So lastly, based on the quality assessment tool, the study where the high quality studies were only 23%, and this is consistent with other reviews, which state that the interventions, exercise intervention for cystic fibrosis ranked between low to moderate. So for strength, this is the first review used to use the ICF model in relation to exercise. And also we can use this to provide a standard framework assessment for cystic fibrosis, and also it can guide comprehensive patient care. For the limitation, based on our tool, the quality assessment tool, some of the items were not applicable to some of the studies, which might have biased our rating. And some of the included studies were conducted over 40 years, and this is a limitation because the ICF was first introduced in 2001. The last limitation was we find difficulty finding some of the questionnaires, and to be specific, we were not sure which questions they ask in these studies. So to conclude, the outcome measures from our studies targeted the body function and activities and participation domain, and the methodological quality of our study are generally moderate. And so for future direction, more ICF categories should be targeted, such as body structure, and also more vigorous methodological design are needed to improve the quality of the studies and to minimize risk of bias. And this can be achieved by conducting more RCTs and controlling for confounding factors. And I would like to thank Dr. Lohman, who is here with us today, Dr. Han from the UAB, and two other students, Noor Al-Malki and Samantha Chris. Thank you.
Thank you, Najla. Now, given that 84 of the 89 papers used respiratory function and 77 used the exercise tolerance, and yet only 23% of the studies were deemed as high quality, can you elaborate on the potential impact of these outcome measures on the quality of research in the future?
Sorry, can you repeat that?
Well, so of the 84 of the 89 papers were respiratory function as
Yes.
the high mark. And then you had 77 using the exercise.
Yes.
And yet of all of those, only 23% of them were deemed high quality. So
Yes.
could you kind of elaborate on the future as far as how that kind of impacts research in the future?
Yes, that's a great question. So in future studies, I think, as I said, like implementing more RCTs can improve, this quality of the studies, and which can also improve the outcome measures in respiratory function and exercise tolerance function.
Thank you very much. Are there any more questions from the audience? Thank you very much, Najla. We appreciate your presence here today.
Yeah.
Thank you.
Thank you.
So next up, it's my great pleasure to introduce Dr. Brenda Button. She doesn't really need many introductions in the CF world, but Brenda has been privileged to work in CF from newborn screen through childhood, adolescence, adulthood over the last 3 decades. She's an accredited instructor of modern airway clearance therapy, learning from the originators of evidence-based techniques. Her research contribution includes airway clearance therapy, effects of gastroesophageal function, mucolytic agents, and quality of life, exercise and exercise testing, continence in women and men with lung disease, and adherence. She has published more than 70 peer-reviewed studies. Welcome, Brenda.
Thank you very much to the organisers and our moderators here for selecting this study to be presented on behalf of our study group, which you can see listed on the slide. I have no conflicts to present. So, background to the study. We know that cardiorespiratory fitness is associated with better outcomes in cystic fibrosis. And we recently developed a new step test, an incremental maximal effort step test for use with adults in CF. We do know, however, that cardiopulmonary exercise testing, CPET, is the gold standard test. And at the Alfred, we use the Godfrey protocol and a cycloergometer as our CPET test. However, CPET is not available at all centres worldwide. It requires expensive equipment, and it requires technicians that are very experienced to interpret the results. Results are not always available in real time for exercise prescription. And we thought with a step test that could be carried out in an outpatient clinic room would be space efficient because it could just be done in the outpatient clinic. And it would comply with modern infection control guidelines, and the results would be available to us for exercise prescription in real time. So the testing equipment that we used was the COSMED K5 wearable metabolic system, and this can be used both as in field testing as well as laboratory testing. This allows us to measure breath-by-breath gas sampling. It has wireless connectivity. It has an intuitive interface which is user-friendly. And the masks that we used were bought with an Alfred Small Projects grant, so each patient got their own mask. And the computerized analysis and data were stored and then used for analysis to present today. And any equipment from this testing equipment was sent to our laboratories for sterilization. So prior to testing our patients, we did look at musculoskeletal issues and any other comorbidities which would make them not suitable for a maximal test. And then when we recruited them, at the time of recruitment, we prepared them for the conditions on the day of testing. And there was always a medical review prior to the first test to make sure that the patient was suitable for maximal exercise testing. So the aims of the study were to demonstrate the validity of the A-step as a maximal exercise capacity test when compared with CPET, which is the gold standard in adults with CF. We had already published the protocol and the feasibility study. So the methods of the study were with our Alfred Ethics Office approval. Adults with CF were invited to participate in the study sequentially. They were required to attend our laboratory on 2 days, 2 weeks apart. And testing was always at the same time of day under the same conditions. So they needed good hydration on the day of testing and to avoid heavy exercise and eating prior to the test. They were to wear appropriate gear, such as sports shoes and exercise clothes. And our main study protocol was 2 maximal incremental exercise capacity tests, 2 weeks apart in random order. So either CPET or the A-step. So say this patient has been randomized to do the A-step first. What happens on the day of testing is they do pulmonary function, FEV1 and FVC, and they complete an ALL score, which is a quality of life a measure that takes 1 minute to complete, and you can see a picture of it on the slide. And this was really for us to make sure that baseline stability was occurring at each testing day and under the same conditions. The A-step was carried out on a non-slip 20 centimeter step, and non-slip is really important. We used an online metronome app, which was free and we could download for external pacing, and a scoring sheet that was developed especially for this. There were standardized instructions and encouragement throughout the test, and we measured oxygen saturation, heart rate, and blood pressure throughout the test. And this test started at 18 steps per minute, which is a very slow pace, and increases by 2 steps per minute. It has a maximum of 16 levels, which is 48 steps per minute, which is actually running quite fast up and down the step. So that shows the recording sheet. In the middle, we have the app with the metronome and the non-slip step. For CPET, we completed as per ATS ACCP guidelines with 12 lead ECG, minute-by-minute manual blood pressure, which is a standard of practice done by a medical doctor at our unit. And either a 10 or 15 watt protocol was used depending on the patient's FEV1 and baseline fitness. And the K5 equipment was used for breath-by-breath analysis. And we also did record heart rate each minute, as well as oxygen saturation and blood pressure. So the main outcome measures for both of these exercise tests was peak heart rate and peak oxygen uptake. Here is Judy doing a test 1 week on the step and the next 2 weeks' time on the COSMED bike. We aim to get at least 90% of maximal heart rate for age, and that is calculated as 220 minus age. We use the modified Borg score, which is 0 to 10, with 10 being maximal, and we encourage patients to be a 9 or 10 out of 10 before they stopped. For dyspnea, which we termed during the test as lungs, and for leg fatigue, which we termed as legs. And testing ideally should occur in 8 to 12 minutes. So these are the first results of the 7 subjects. In the first column is the A-step, second column CPET, and this is looking at maximum heart rate. And we can see that in 5 of the 7 patients, the heart rate was slightly higher in the A-step, and 2 of them were almost identical. This was not significant difference. The mean A-step maximum heart rate was 174 and CPET 168. And the R-squared correlation was 0.85. When we looked at VO2 peak, which was our other main outcome measure, we again see the first column A-step, second column CPET, and we can see there's quite a range. And again, at least 7 of the patients got at least as good as the CPET in terms of VO2 peak per kilogram. And when we look at the significance, it's non-significant. The mean for the A-step was 31.3 versus 29.8 for CPET. And the correlation was 0.77. So this is a very busy slide with all of the information that we regarded as relevant, but what you really want to cast your eyes to is all of the numbers that are not coloured in yellow. They are all non-significant differences between the 2 tests. The only ones that were different that were legs. They just made significance. Probably because on an exercise bike you may be working the legs a little bit harder than when you're stepping up and down a step. And the others were probably related to the kinetics of the test, which made them significantly different. In other words, stepping up and down, lifting your whole body up and down a step versus being seated and exercising with legs. We looked at the Bland-Altman plots, and we can see in the first column the peak oxygen consumption with the R-squared of 0.77, then maximum heart rate, followed by 0.85 correlation, and the maximum ventilation, followed by correlation of 0.82. When we look at the lowest oxygen saturation, or the nadir for the SpO2, and here we can see the correlation, 0.67, the respiratory exchange ratio with a correlation of 0.44, and exercise duration, 0.48. This is one case study, the first one we actually did. She was a 64-year-old female. She had good lung function, now on gene or CFTR modulators, FEV1 of 85%. Her OR score on the first day was 71 out of 100, and on the second test day, 74 out of 100. So we could really tell, as well as with her FEV1 being 85 on the first day and 87 on the second day, or the second testing day, that she was very stable for both of these tests, very much under the same conditions. This is her 9 graphs under CPET, and this is the same graphs when she did the A-step. And we put them side by side, not going to comment a lot on them, but just for you to, those of you who really understand all of these well, will be able to just cast your eyes between the two, CPET on the left and A-step on the right. So the VO2 peak was selected as one of the outcome measures, as it is the highest amount of oxygen consumed during peak exercise, and it's recommended as the best measure in cystic fibrosis. The treadmill exercise test activates more muscle groups, it's believed, maybe than cycling. And the VO2 max is generally higher than in a cycle ergometry by 7 to 18%. And we're using that to maybe interpret the slight differences between the tests, between the kinetics of the test. So it's likely that the kinetics of the A-step may have a similar effect on oxygen uptake where you're using whole body rather than being in a seated position. So in conclusion, in this pilot study, the A-step achieved comparable exercise times, VO2 max, heart rate max, RER max, SpO2 nadir to standard CPET cycle ergometry. However, VE max and VO2 at the anaerobic threshold were significantly different, and we think this could be attributable to the differences in these exercise kinetics between these two different types of testing. And I think the conclusion here also is that a larger trial, including adults and children, is warranted. This is the acknowledgements of getting 7 subjects to be prepared to come 2 weeks apart to give up 2 of their working days. Very hard to recruit in this day and age. And the other members of the team and suppliers of our equipment. And these are our references of the other 2 publications. And I now invite you to discuss or ask questions. Thank you.
Thank you, Brenda. That was an excellent presentation, and we've already got some questions in the app, so I'll start with those. Was there any cardiovascular risk stratification used to determine overall safety? In terms of musculoskeletal limitations, was that determined using any functional testing?
Well, that's 2 parts to the question. Look, we did discuss with the medical team, each of the subjects would be suitable for exercise testing. So it was just a general medical opinion. And in terms of musculoskeletal, it was a questioning whether they had any problems that would stop them from being able to do maximal exercise, sitting on a bike or stepping up and down the step. So they were more pragmatic, kind of usual history taking as physiotherapists.
Thank you. Another question. Okay, my apologies. Was RER used or only 90% of age predicted heart rate max?
Well, they were all tested, but we were looking for at least 90% to show that you could get on a stepping up and down maximally with a Borg score of 8 or 9, that you could get to at least 90% of max. Many of them did actually reach full maximum heart rate, but that was certainly a goal, to get at least 90%. Gemma's there for a question.
Thank you. Brenda, that was brilliant. Thank you so much for that presentation. I just wanted to ask you kind of reported that the correlations for exercise duration were lower, so like 0.48, although in your discussion you said the exercise times were comparable. I just wondered if you could kind of say maybe why the correlation was lower. Was there a sort of a difference that might come out with more people?
No, I think it's just one of those statistical things, because we know correlations can work in both directions. Because when you actually went back to the slide, the big busy one, the time was very similar between them. I could go back to that if you want to see that. But no, there was no particular, I think it's just a quirk of statistics.
Thanks.
Thank you.
Was there an FEV1 cutoff for exclusion?
Not a firm one. We wanted a broad range. And it so happened that in the 7 that we were able to recruit, that 40% was about the lowest FEV1. But we did want to try and include right through from quite advanced lung disease right through to people with 100% FEV1. Thank you.
Maybe the last question. Do you think the A-step can be used in the pediatric population, and will it need adjustments?
That's an interesting question. When we did our feasibility study, the Adelaide Women's and Children's Hospital did a number of tests as well, and that's been published. From memory, there were around about 10 children over the age of 12, I believe, who did the test very successfully. So it was found to be feasible in mature enough children who could actually follow the instructions. But it's something that needs a proper full study in the pediatric population. Thank you.
We'll maybe have one more final question. Are there termination criteria for your STEP test in terms of vitals?
Okay, so with all of these 7, we let them continue on right to the end when they got to at least an 8 or 9 out of 10 for either their leg fatigue, legs, or shortness of breath, lungs. If our gut feeling was that this person wasn't doing well or not looking great, if there was an intuitive feeling, we would have stopped them, but we didn't feel that with any of them. One of them, the one with the lowest lung function, worked really hard, but was stable and steady through to the end. So no, there wasn't any particular one that we had to stop. But when we look at our whole population, we do have to think about how people are going, and if they start looking as though they're not doing very well, we would certainly stop them. And if their oxygen saturation dropped down too low, and there's always a question about how low is too low, but generally below 85, we have been down to 80. None of these got below 90, so it didn't become a problem. But certainly knowing your patient and then looking at their drop in lung function would be something you'd have to keep track of, and just watching them carefully. There were 2 of us physios who did this together, and we were experienced and would stop if we thought things weren't going well. Thank you.
Thank you so much, Brenda. It was a very elegant study.
Thank you very much.
Thank you again. We also want to acknowledge the people who are joining us online. Thank you so much for being with us this morning. Next to the stage, please welcome Dr. Taylor Lewis, the Director of Human Performance at the Pulmonary Performance Institute. He brings a wealth of experience to the table, having served as a strength and conditioning specialist for over a decade and a clinical exercise physiologist for the past 5 years. Academic achievements equally impressive. He carries degrees in kinesiology and a PhD in health and human performance. And he is dedicated to improving the lives of individuals with CF and collaborates closely with clinics to develop innovative exercise programs that enhance both health and human performance. So let's extend a warm welcome to Dr. Lewis as he shares his research. Peripheral muscle testing correlates with inspiratory strength and lung function in cystic fibrosis. Dr. Lewis.
Thank you, everyone, for this opportunity. I really appreciate it. This is some research in the last few years we've been collecting, so I'm excited to share this with you guys today. So our topic, peripheral muscle strength testing correlates with inspiratory muscle strength and lung function in CF. I have nothing to disclose, no relationships here. So introduction, people with CF commonly present with decreased lung function, muscle mass, peripheral muscle weakness compared to healthy age-related individuals. We know that hand grip strength is positively and significantly associated with lung volumes in healthy age-related adults. And we know it's a strong positive predictor of FEV1 in the same population. So we wanted to first aim here. Our first aim was first to determine if there's peripheral muscle strength correlates with lung function in people with CF. Then we did a secondary aim that, to my knowledge, hasn't actually been done in CF yet. And this is where we looked at if muscle strength correlates with inspiratory muscle strength. A lot has been focused on FECs, FEV1s, but to my current knowledge, I looked actually today, there's nothing that's looked at MIP testing, which is going to be something we want to potentially look towards the future at looking at too. All right, so our inclusion criteria consisted of people diagnosed with CF, disregard the healthy controls, that shouldn't be there. People with CF 18 years of age or older, able to perform PFTs, MIP, and grip strength testing. They had to be clinically stable and lung function greater or equal to 30%. Anyone that's been hospitalized in the last 3 months or has had an acute pulmonary exacerbation was excluded. Any orthopedic injuries that would cause them not the ability to do it, or musculoskeletal disorders that they weren't able to do grip strength and FEV1s less than 30, and unable to understand the protocol of the study. All right, so with our testing here, we started with, we administered, see on the right a picture of the participants at hips, knees at 90-degree angle, upright position with their elbow at a 90-degree angle. Now, this picture was actually taken in my clinic, but in the clinic we did this. Most chairs had an armrest, and so they rested their forearm on there. And then I would hold a handle. So if you look at the bottom handle, this is a digital jammer device. I would hold it for stability, and we would do 3 test trials, collected peak and average means. Our focus was peak because we're trying to see what their maximal output is versus their mean. So we collected both, but focused on peak. And then they had 30 seconds of rest between each set. So they would do 3 on one arm with 30 seconds of rest in between, and then 3 on the other with 30 seconds of rest. We didn't do alternating, we stayed on the same side. And then from there, we did a couple questionnaires. So the Golden Leisure Time Exercise Questionnaire is used to quantify physical activity levels. It's a very reliable one. If you look in this one, if you can see, it's subcategorized based on strenuous, moderate, or light exercise. What I would ask these individuals is how many times per week would you perform strenuous, moderate, or light exercise for 15 minutes? If they didn't understand what moderate, light, or strenuous kind of subjectively felt like, we used a modified rate of perceived exertion scale, 0 to 10. Then we would calculate that times per week, times it by that within that subcategory. And then it was categorized based on units. At the bottom of this, you'll see 24 units is considered, 24 or more is considered active. 14 to 23 was considered moderate, and then less than 14 units was considered sedentary or inactive. From there, I asked them how many days per week they participated in 20 minutes or more of resistance training based on the American College of Sports Medicine guidelines. Just anecdotally, just so people kind of know, that varied from body weight strength training to resistance bands, weights. Anything of that level was considered as long as it's 20 minutes or more. And then we collected demographics of health history, age, sex, height, weight, BMI, FEV1s, FECs, ethnicity, CFTA modulators, and CFTA TR variant. So with our results here, so we had access to about 208 participants. We ended up excluding 39 because they didn't meet the criteria. 10 were duplicates, and then 4 refused. After 155 consented, the secondary analysis was we had 86 participants of that 155. So when we're looking at the characteristics here, on average, these adults were about 35 years of age, males and females. FEV1s categorized, 38% were 90% or above. 89% was 29. And so it was evenly distributed, except when we get below 40%. Most of the individuals were non-Hispanic, non-Latino. This was at the Stanford Adult CF Clinic in Northern California, and that tends to be the population over there. And then about 80% were on ETIs. So when we talk about, just to give it a background on kind of people's physical activity levels and stuff like that, on the y-axis in the first graph, we had a percentage of participants, and then on the x-axis, days per week of resistance training. So about close to, or 39% of them didn't perform any resistance training whatsoever. And then about a little over, it was like 53% performed 2 or more days of resistance training. And then on the right-hand side of the graph, we have percentage of participants on the y-axis. On the x-axis, when we categorize that physical activity levels, we found about 36% fell in the sedentary category, 23% moderately active, and about 38% active. So over 50% were doing some form of physical activity, and that goes with some level of resistance training. One thing to just consider here, we didn't calculate the intensity of these parameters, and that's something we'll discuss later about. So what we found in all adults, hand grip strength correlates with FVCs. However, it's a weak correlation. So we then took it another step and we tried to introduce some covariates. And we're doing a multiple linear regression. We introduced, these are the 4 that are on this chart. We introduced other ones, but none of them were statistically significant, just like these ones. But the ones I wanted to focus on was physical activity level, resistance training, and we did BMI just because we know there's a correlation there with lung function. And none of these had any statistically significant correlations as all adults. However, as we start to move in, I did a sub-analysis because we know males and females are different when we come to overall musculoskeletal strength. So we wanted to see if there was any differences. And we did, in a sense, see on the female side that there was some statistically significant predictors of FEC was peak hand grip strength, BMI, physical activity levels. One thing we do think is potentially the BMI was a potential driver when we introduced it, because when we look at just hand grip strength and physical activity levels, it wasn't a statistically significant, but once introduced with BMI, it was. So there's potential something we're going to be looking into there. Now, when we look at FEV1s, we didn't see any statistically significant correlations here with all adults. And then when we introduce covariates, it's happened to be the same thing. BMI, physical activity level, and resistance training, nothing had any significance. However, once we shifted from in sub-analysis to sex, we did find once again on the female side that BMI, physical activity level, were correlated with FEV1s here. So our secondary analysis, we introduced maximum inspiratory pressure. So if that's assessing where obviously our diaphragmatic strength, our inspiratory muscles in a sense. And what we had them do here was 3 MIP pressure tests with a 1-minute rest in between. So when they were in the clinic, they did their PFTs, they rested as much as needed, and then they performed this secondary. And this also was in line with timeline with our hand grip strength. We made sure to make those standardized across the board. So it was PFTs, then we do some level of grip strength, and then MIP testing. And then we collected the peak measurement, and then we looked at the differences. So one thing to consider here is there is a statistically significant difference in MIP in males versus females. Then when we started to look at what if it correlates with MIP, we actually saw the opposite in a sense here, where there was a statistically significant correlation with a moderate effect, but it was more driven by the males. And so from there, we kind of looked at the covariance. And in adults, once again, we didn't find anything altogether. However, when we broke it down by sex, we did see on the male side, physical activity, resistance training, and combined together resistance training with grip strength had a statistically significant predictors of MIP peak. Potential differences there that we saw that could be driving this as well is there was a statistically significant difference in overall peak grip strength, males versus females, with males having higher, and it was about 20 kilograms higher. And then when we looked at the physical activity per week, once again, males had more physical activity, and it was about 40 units higher. And then with resistance training days, males on average did 1 more day per week of resistance training. Now, once again, We didn't measure any intensity. We didn't measure potentially if they were all doing it in the gym, whether it was videos, whatever it might be. So that's something we're going to have to look at down the future. But this is a general idea of why potentially this subgroup shifted and had higher MIP correlations with grip strength comparatively to FEC and FEV1. So summary and conclusion here. Grip strength reported a statistically significant correlation with FEC in adults with CF. BMI, resistance training, and physical activity did not predict this correlation. Still unclear if other factors may contribute due to this weak correlation. We did observe some potential differences between males and females in FEC and FEV1. However, the study wasn't powered to analyze sex. So when we first initially did this, it was overall adults. And then we just wanted to see, since the participants we had, when we subcategorized, it wasn't powered strong enough to potentially show us what potentially could be, in a sense. So more subjects are needed to clarify the true relationship with sex, hand grip, and lung function. And then MIP correlates with grip strength in adults. Hand grip strength, resistance training, physical activity were significant predictors in MIP in males, but not in females. There was a statistically significant difference in grip strength, resistance training, physical activity, as I discussed, in males and females. So we further need to look into categorizing at what intensities are these people exercising, at what intensity they're doing the resistance training, because it's very clear in the literature that the higher intensity exercise can drive better pulmonary function, and then also musculoskeletal strength. Same idea, people that lift heavier weights tend to potentially build stronger muscles. And also, depending on what we're looking for, in a sense, some people's goals is muscle endurance, muscle hypertrophy, or maximal strength. And those things need to be categorized so we can understand potentially what's driving that. Limitations. All right, perfect. So once again, CFTR genotype function may be impacting results. It's something that we didn't necessarily look at, but that's a potential there. As I've said multiple times, intensity was not categorized, and that's something we're actually going to probably go back and reanalyze to see. And it's a relatively small sample size in a sense. We are working in collaborations with another clinic in the Central Valley in California that's currently doing the testing, and we tried to potentially get some of that data, but unfortunately we don't have that. So we're hoping to have a larger sample size coming soon to potentially see if things change at all, or they validate what's currently been presented here. And then just further research, I do believe we need to look at lean body mass versus BMI. There's, as probably a lot of people are well aware here, that's not going to necessarily drive our quality of body function, in a sense. Understanding how much lean mass the individual has could be a potential predictor to allow drive us. And so we need to look at lean body mass potentially versus BMI. Multiple center studies, we need longitudinal data or longitudinal studies to see, is this paralleling across many years? Is there any correlations with that? And then once again, I'll reiterate research intensity, physical activity to see if there's effect on grip strength, MIP, and lung function. Just acknowledgements from the team at Stanford, who was very kind to collaborate with me. The staff here has helped me tremendously, so I would not be up here without them. So I really appreciate the team at the adult and actually pediatric clinics to be able to share this with you. All right, any questions?
We do have a few from the app. Regarding resistance training classification, 3 sets of 15 burpees may take less than 10 minutes. This would be fairly intense training, but would be classified as no resistance training per your definition. Is that correct?
Yeah, that would be more aerobic or anaerobic based training.
Thank you. Second question from the app. Would you consider using quad strength versus hand grip strength in any future studies?
Yeah, so how we set this up, and there's actually two ways of doing the grip strength. We did it based on what's been tested across populations with CF, where you sit in a 90-degree angle. However, there's a lot of data coming out that doing it standing, in a sense. We'll get to quad strength, but standing, which is going to probably give you more full body strength because you can leverage your legs. And they've actually shown people to have higher grip strength standing versus sitting. So that could potentially have a better parallel to potentially lower body strength. But both of them, I would say, would be good in a sense because it's really hard to do one repetition max strength training. Just like doing cardiovascular exercise testing, people don't have access to the equipment, the time, and grip strength, whether it's seated or standing, has been highly reliable and correlates with one rep max testing. So yeah, looking at lower body strength would be key as well.
Right. And when this data was collected, was this using the prior GLI 2012 or was that moved to global?
The prior one.
Looking at our transgender population, how would this be applied? As far as, because you noted a difference between the men and women versus some of, and so in consideration of our patients who are transgender, the classification.
Yeah, so from what I've read currently, there's not enough evidence to support classifying difference than their biological sex. Now, over the next 5-10 years, that may potentially change, but as of right now, that's the only thing I could probably answer in a sense of keeping it based on biological sex.
Thank you very much. Do we have any other questions from the audience? Great. Thank you so much for sharing that information today.
Next up, I'd like to invite Lynn Adams to the stage. Lynn received her BSc PT in 1991 from Western University, London, Ontario, works as a physiotherapist at London Health Sciences Centre in London, Ontario. She's worked in various positions at acute care hospitals, including St. Joseph's Hospital, London Health Sciences Centre, and for the past 33 years, with some pauses in her career while raising her 4 children, she's continued to work as a physiotherapist. She has a special interest in cardiopulmonary physiotherapy, and she's currently the physiotherapist at the adult CF clinic at London Health Sciences. Today, she is going to present her paper, Are Adults with Cystic Fibrosis Choosing to Continue with Airway Clearance Therapy in the Era of Highly Effective Modulators?
Thank you. Good morning, everybody. As Claire said, I've been a physiotherapist for 33 years. But I have been working in the adult CF clinic for the last 2 years. So I was able to attend my first NACFC conference last year, and I was just blown away by the level of knowledge sharing and networking that went on. So I wanted to get more involved. So this is a first for me. So a big topic of discussion at the last conference was that patients were doing less airway clearance therapy, but to what extent? So I wanted to know more what was going on in my own clinic and be able to compare to what was going on in the other clinics. So the research question became, are adults with cystic fibrosis choosing to continue with airway clearance therapy in the area of highly effective gene modulator therapy? And I don't have any relationships to disclose for this presentation. So a little bit of background, which will be reviewed for most of you. CF is caused by mutations in the gene that produces the CFTR protein, and this disrupts the normal production of or functioning of that CFTR protein. Specific to the lungs, this leads to compromised mucociliary clearance, and studies estimated a decline of minus 1.5 to 2.7% decline in lung function per year, depending on the age and cohort. The use of airway clearance therapy is recommended for all people with CF, as this facilitates the movement of and expectoration of mucus, keeping the lungs clear. Usually this is started soon after diagnosis and performed at least daily for the rest of their lives. Along comes the introduction of highly effective gene modulator therapy, such as specifically ETI. This has greatly improved the lung function and quality of life for those people with CF who qualify for this therapy. Recent studies for people with CF on ETI show projected survival of 72 years. In US, the FDA gave approval in October of 2019 for age 12 plus, and in Canada, Health Canada gave approval in June of 21 for the same age group. In March of this year, CF Canada released a consensus statement from the Canadian Cystic Fibrosis Physiotherapy Advisory Group, which consists of about 80 physiotherapists across Canada that work with children and adults with CF that give input, and an executive of about 8 physiotherapists. So the consensus statement was, with a significant improvement in lung function and quality of life for people with CF who are taking modulators such as ETI, the group strongly recommends regular airway clearance therapy to keep the lungs healthy and maximize the impact of the modulator therapy. The objectives of the study were to describe and explore the following: the characteristics of people with CF on ETI, changing trends in airway clearance therapy routines, looking at before ETI and currently while on ETI, and looking at reported exercise routines, both pre and while on ETI. And lastly, looking for any differences in continuation of ACT in people with CF who determined by the ACFLD criteria with an FEV1 of less than 40%. So this was a retrospective cohort design. So a retrospective medical record review was done at a tertiary care teaching hospital. It's at the adult CF clinic. The inclusion criteria were if they were 18 or older, CF diagnosis, and currently on ETI. And the medical records were included if they met that criteria. Demographic data was collected, and subjective reports of airway clearance therapy and exercise looking at before ETI and the most current data available. And exercise for this purpose was fairly broad, looking at going from walks to gym routines to some doing competitive sports. Descriptive statistics were used to analyze the demographic data. Statistical analysis using 2-sample t-tests with equal variances on ACT and exercise reports were done, and also a Tobit regression analysis controlling for the demographics such as age, sex at birth, CF genetics, and FEV1 was done with ACT being the dependent variable. Looking at the results, 149 medical records were reviewed, 93 subjects met the inclusion criteria, and subjective reports of ACT and exercise were available and collected on 81 of the 93. So the age, the mean was 32 with a range from 18 to 65 years. 41 of the 81 were female. The genetics, 46 of the 81 were homozygous delta F508. And the ACFLD status, there were only 7 of the 81 that met that criteria. And for years on ETI therapy, the average was 2.5 years, ranging from 1 to 4 years. And just to note that we did have a few patients that received access on compassionate grounds before June of 21. That's why we have some patients that were on it for 4 years. For the results section, this was not part of the statistical analysis, but just wanted to include this showing the popularity of the different types of airway clearance therapy. In our clinic, clearly PEP is more popular, and I understand in the States it's more likely to be the best. So the blue bar is just showing before ETI, and the gold one is most currently what they're doing. So I included this figure because previous research looks at the percentage of patients that either decreased or discontinued their airway clearance therapy after starting ETI. So in our case, 75% of the patients, that would be 16 of the 81, had either decreased or discontinued the airway clearance therapy altogether. And we break that down further in more detail with statistical analysis. So looking at airway clearance therapy, what we did was we pooled the various forms of airway clearance therapy. And on the left-hand side, we have a chart, an indicator test saying, are they doing any airway clearance therapy? So before ETI, 95% of the patients did some amount of airway clearance therapy. And currently on ETI, 65% are doing some form of airway clearance therapy, and that's significant at the 1% level. And we also looked at the frequency of airway clearance therapy. And before ETI, it was 11.5 times per week. and currently on ETI 4.6 times per week. And again, that was significant at the 1% level. This is where we use the Tobit regression, where the dependent variable, as I was saying, was airway clearance therapy count, and we controlled for the patient characteristics. And even with that test, it was still statistically significant difference at the 1% level in the amount of ACT done per week, pre to post. Looking at exercise, we again looked at it in two ways. And then on the left is the chart saying, did they do any type of exercise? So pre-ETI, 64% of the patients said they did some amount of exercise, and on ETI, 84% said they did. And that is significant at the 1% level. And looking at frequency, we only had frequency information on 73 of the 81 subjects. And look before ETI, 2.3 times a week, and increasing to 4 times per week on average. And again, significant at the 1% level. For objective 4, we didn't find any correlation between the severity of lung disease and the continuation of ACT, but there were only 7 of the 81 patients that met that criteria. So in terms of discussion, our findings were consistent with other studies in the sense of the same trends. In BC Children's Hospital earlier this year, they reported a 27% of their patients either decreased or stopped ACT, and they had a similar range of ETI use from 1 to 4 years. In the adult side, there were a couple of studies. One looked at airway clearance therapy at the 2-year mark. And one study said a third of the patients decreased their chronic daily therapies, which did include ACT. And another study said that the baseline adherence went from 83.5% down to 70.5% at the 2-year mark. And then with respect to exercise, one study reported that 64% of the patients slightly or significantly increased their exercise after starting ETI. And in another questionnaire design, 93% of the patients reported regular exercise as a means of augmented airway clearance, and 11% reported that exercise replaced their traditional ACT. And then just noting that in a 2022 Cochrane review of ACT and exercise, they reported that there was an insufficient number of trials to conclude whether or not exercise is a suitable alternative to ACT, and they were uncertain about the effectiveness of exercise as an ACT. So in conclusion, on the one hand, we are recommending that patients continue with their airway clearance therapy, but clearly a significant number of patients are either decreasing or discontinuing their ACT, while also significant number of people increasing their exercise. So in terms of next steps, I think to evaluate the long-term impact would be good. With patients decreasing or stopping their ACT, looking at pulmonary exacerbations, looking at overall pulmonary health, seeing if that's impacted. And then with respect to exercise, further research needs to be done to look at whether exercise can be considered an ACT equivalent. And because as we said, they are making these changes on their own. Just in terms of acknowledgements, I just wanted to thank LHSC. I wanted to thank the physiotherapy department for supporting the research, and the library services for helping with literature searches, and Cystic Fibrosis Canada for providing the clinician education grants so that I would be able to come to this conference. And some people said that they might not know where London, Ontario is, so I put in a little map with a little star there above Lake Erie just to show where we came from.
I'll start with questions from the app. Given both airway clearance and exercise are used as forms of clearance, why do you believe there was an increase in exercise after initiating ETI?
I think a lot of it is that they're feeling better. A lot of patients will say they're not getting as short a breath. They're actually able to enjoy the activity, whereas it was more of a chore before.
Did you look into those who stopped airway clearance and whether or not they had a decrease in FEV1 or an increase in pulmonary exacerbations?
We were thinking that part 2 of the research may be to look at pulmonary exacerbations. That'll just take a bit of time. So we haven't looked at those correlations yet.
I'm sorry if you said that. Did you find that anyone with advanced lung disease, so FEV1 under 40%, replaced airway clearance with exercise, or did most of them continue their airway clearance? Or did you not specify like the difference between?
For that group, there were only 7, and we didn't find a correlation as that whether they were doing more airway clearance therapy than the others, but I don't know if I fully understood the question.
Did any of them with like lower lung function like stop airway clearance and just use exercise? Any of that group, or?
I didn't pull that data specifically for that. I just wanted to see more if there was a correlation that they were doing more airway clearance, but that would be good to look at. No.
Thank you very much for this. This is great. When you say that patients are stopping airway clearance therapies, is that on their own? Are they making that decision on their own, or are they being recommended to do that? I just want to get clarification on that.
No, this is something that they've decided on their own. I still, because I work with the adult population and they have, at this point, several years that they haven't been on ETI, I still recommend, given that there are likely changes in their lungs for their optimal lung health, to continue with airway clearance therapy. But when I asked the questions, I was saying, tell me what you're doing.
And I just wanted to put a plug in for a session this afternoon. Your last question there, exercise versus ACT, it's not very clear in the app. It says it's at 2:30, Symposium 10, your case, airway clearance versus exercise in the new era. It's actually a debate on your final question there. So
Right, and I know.
it should be pretty good. I've heard it's very good.
So knowing that there are adherence issues with airway clearance, do you anticipate future studies looking at adherence issues with exercise, and any ideas on how to address those barriers in either similar or different ways to adherence to airway clearance?
Well, I think with exercise, they're increasing it on their own just because of how they're feeling. So I don't see as much of an issue with adherence to exercise as to the airway clearance therapy.
Hello.
Hi.
I'm curious if there are any recommendations for our patients who are more interested in exercise versus airway clearance in ways that they can be more actively breathing through their exercises so they're getting more beneficial airway clearance simultaneously.
Right. That is a good question. I know a lot of the patients, after their activity, they'll do some of their, autogenic drainage or active cycle breathing, just in case they have loosened up a lot of the secretions. So I do encourage that.
Okay, wonderful. Thank you very much.
Thank you.
I would also like to say, come to the debate.
Yeah.
Thank you so much. All right, we had such a full schedule. We are so glad to have introduced our final speaker of the morning. This is Dr. Emma Raywood. She is a pediatric respiratory physiologist with a deep commitment to improving the lives of children with CF. Her work with the London CF collaboration has provided invaluable insights into the long-term effects of the disease. But her most recent project, Project Physio, represents a truly innovative approach by utilizing remote monitoring technology. Her team was able to collect a vast amount of data on airway clearance techniques and physical activity. And by reviewing this data, they were able to identify patterns in treatment behaviors and impacts on clinical outcomes. And additionally, they have explored the potential of gamification to enhance treatment adherence. Today, she's going to share her latest findings on the impact of AC-driven gaming on treatment outcomes. This research really promises to revolutionize the way we approach management of CF in the future. So let's give Dr. Raywood a very warm welcome as she presents the impact of breath-controlled gaming on the quality of airway clearance treatments in children with CF during Project Physio.
Thank you. That was a lovely introduction. So I was lucky enough to do my PhD as part of Project Physio, which was a longitudinal observational cohort study of physiotherapy for children and young people with CF. Briefly, it used remote monitoring to capture breath-by-breath airway clearance data from 145 children and young people from 3 cystic fibrosis centres in London over 16 months. It was designed to provide insights into airway clearance treatments, one of the most burdensome treatments for people with CF. And current care guidelines, as we just heard, recommend daily airway clearance to facilitate the removal of mucus from the airways. If you wish to find out more about the wider study, you can access our YouTube video or our protocol using this QR code. And my talk references are on the QR code as well. This talk is only about part of the study, in which the aim was to see if gamifying airway clearance treatments would help improve adherence and reduce burden. There are many airway clearance techniques, and in the latest UK CF registry report, it showed that 75% of children and young people and 47% of adults with CF used positive expiratory pressure, PEP devices, as their primary or secondary airway clearance technique. So Project Physio focused on these techniques. In this picture, you can see 4 of the most commonly used ACT devices at the recruiting sites, the PariPEP and AstraTech PEP devices on the left, and the Acapella and Aerobica oscillatory PEP devices on the right, which also provide vibration. Project Physio developed a bespoke piezoelectric pressure sensor to attach to these PEP and OPEP devices, and you can actually see it attached to all the devices in these pictures. The sensor was battery-powered, wireless, used Bluetooth to sync data, and did not change the functioning of the devices. The sensor had 2 jobs. First, to record ACT data, and second, to work as a breath-controlled joystick for gaming control. The sensor recorded the quantity and the quality of every breath of every treatment. Quantity was easy for the sensor to measure. It simply registered how many breaths per treatment and how many treatments per day. Quality was a bit harder. We scoured the literature for details of how PEP and OPEP treatments should be carried out, and found these common threads of advice for all 4 devices: that breathing through the device should be at tidal volume with only slightly active expiration, not prolonged or forced, and the appropriate resistance is one which achieves a stable mid-expiratory pressure of 10 to 20 centimetres of water. These were the criteria we used to define a good treatment. So when the sensor measured a breath that met these criteria, we considered it a good breath. And when the treatment contained mostly breaths which on average met these criteria, we said the treatment was performed as recommended. We'll keep coming back to this as it was our benchmark for quality. Adherence to treatment frequent. Project Physio has already described ACT quantity and quality for the first 2 months of the study in the journal of Cystic Fibrosis, the reference is here, and also on the QR code. And adherence to treatment frequency varied between participants, and although most did the prescribed number of breaths per treatment, the quality of the breath profiles told a different story. This figure shows single breath examples from different patients using different devices that were recorded in Project Physio. On the left, we've got OPEP devices and PEP devices on the right. And here you can clearly see some short and high pressure breaths on the left and longer, lower pressure breaths on the right. We expect breath profiles to look like D. The breath has got a sustained mid-expiratory pressure. However, we observed that most children and young people had very different breath profiles to this, and it was quite different from what we expected. Sometimes the differences were due to the specific device, and other times participants just had their own unique breath profiles. This figure was published by Filippo in the ERJ, and it shows mid-expiratory pressure on the y-axis and the expired breath length as a percentage of a personalised age-related threshold on the x-axis, and plotted are about 50,000 treatments collected during Project Physio. Treatments in that blue box have a pressure and length that can be considered to meet the description in the guidelines. It's about 9,000 treatments. 21% of treatments are in that blue box and match the breath profile that's prescribed. The majority of children spent hours each day doing ACTs that did not match with recommendations. Considering the examples on the previous slide, A is too strong. It's both too high a pressure and too short a length. B has a mid-expiratory pressure in the right range, but the breath length is too short. C has a mid-expiratory pressure in the right range, but the breath length is too long. And D is Goldilocks. It's the just right in terms of both length and pressure, and it's in that blue box. So A and B are OPEP examples, and C and D are PEP examples. And there appeared to be a difference in the most common breath profiles based on whether PEP or OPEP were used. So few OPEP breaths had longer than recommended breath length. The majority had a higher than recommended pressure, and only 9% of OPEP treatments were in that blue box. The majority are from efforts that were just too strong. Conversely, PEP treatments tended to have a lower breath pressure, but more of them were longer than the desirable breath length. Many were too long. However, overall, more PEP treatments were within that blue box. We saw that it was possible to be in the blue box no matter which device you used, as long as people were careful with how they carried out their techniques. But in general, whatever you used, most breaths did not meet recommendations. So next we wanted to see whether doing ACT treatments according to recommendations actually mattered. So in the same paper, we investigated whether children that did ACT treatments as prescribed had better lung function across the 16-month study period. Accounting for other important factors, such as if they were on modulators, their age, their recruiting site, the number of IV antibiotic courses in the past 12 months, we started first by looking at all of the ACT treatments, and there was no association between doing more treatments and FV1% predicted. This line, I think you can agree, is pretty flat. When the treatments were classified as conformant or not conformant, in the box, out the box, the quality of treatment, the quantity became important. So the more good quality ACT treatments per week, the higher the associated FEV1% predicted. And furthermore, doing more non-conformant treatments per week had a negative effect, which was greater than doing no treatments at all. It's not just whether children and young people do their treatments, it matters if they do them correctly. This is explained further in the reference. So gaming presents an opportunity to modify airway clearance techniques to be within these recommendations. As a first step, we wanted to see whether we could change ACTs, and then if this proved to be true, there's an opportunity to modify existing devices, maybe to provide breath-activated feedback. One thing to say is at the start of the study, when we designed the games, we didn't know quality would have such an important impact on outcomes. We designed the games before we knew about the blue box. So let me take you back to 2017 to explain how we designed the games for Physio. We worked with a team of experts from Microsoft to hackathons with computer science students at UCL, University College London, and Abertay University in Scotland. And it was a rich collaboration between clinicians, researchers, industry. At the hackathons, we could see a whole lot of the game designers were blowing too strong, hard, and fast into the devices. And it became clear that discouraging powerful breaths, kind of peak flow type breaths, and encouraging sustained but not maximal blows was going to need to be the target of the games. As such, the framework was designed solely to encourage longer breaths. Nothing was done to try and manipulate pressure or to try stop breaths from being too long. And as you will see, that didn't turn out to be ideal. In total, over 20 games were designed and 5 were taken forward to be released for participants for 8 months, and they were not mandatory. Though the framework was consistent, there were a variety of different mechanics chosen to improve the potential acceptability to a wider range of patients. And one of the most popular games was QB, which was developed by Microsoft. At the start of the game, participants entered their personalized prescription, and they also did a calibration breath, which is on the left, which would set the minimum breath length needed to score in the game. The aim was to blow long enough to complete the cube and do it enough times to finish the level. Using a button on the sensor, participants could make the cube jump to capture coins, which would add to their score. At the end of each set, patients had an enforced break where they were encouraged to huff, as shown here. Another popular game was Temple of Bloon, part of the Archipelago game world, and this was made by Abertay University students. At the start of the game, the player would set their prescription, calibrate, and then be shown instructions how to play. And basically, every breath would try and fill up this power bar at the bottom, and then when it was full, they could shoot the balloons. So if the breath was too short, they weren't able to play. At the end of each set, they were encouraged to huff and cough with an enforced break. So if I show you a case study of one patient, this plot shows the breath length data for one participant before games were available. Each dot is 1 day of the study, and the y-axis is the expiratory breath length during treatments. As you can see, their breaths are under 1 second long on average, very short, and they did not meet criteria. During the next stage of the study, games were still not available, but they were now given feedback on the number of breaths they've done per treatment, and the number of treatments they're doing increased, but the breaths are still very, very short. Then we introduced gaming, and their breaths are now double a length. They're approaching 2 seconds, and they're within that blue box. On some days, there are still lower breath lengths, and that's the days where they chose not to play games. So next, we looked at participants who'd recorded at least 20 treatments with and without the games during the gaming stage. That was about 2,000 breaths minimum. And that meant we had enough data to compare gaming and non-gaming treatments within participants. This was about a third of the participants and around 10,000 treatments recorded in the gaming stage. Just looking at OPEP first, pressure and lengths on their own, the aim of the game was to increase breath length, and it worked. Without gaming, 19% of treatments were conformant for breath length, and with gaming, 42% were. So the amount in that blue box for breath length increased by 23%. And if you want to see why, this purple arrow explains it. Breaths that were too short became longer, moving into that blue box. But those that were too long also became longer, moving away from the blue box, which is why the too long breaths has also increased. Even though the games were designed to increase breath length, to achieve these longer blows, patients also couldn't sustain the higher pressures, so pressure inadvertently reduced by 18%, shown by this second arrow. So gaming can alter ACT quality and can make treatments have breath profiles in the clinically beneficial range. So now let's look at PEP, which you'll remember had longer breath lengths without games to start with. Once again, the aim of the game was to increase breath length, and it worked. So breaths that were too short became longer, moving into that blue box. 14% less treatments were too short. Great. But those that were too long also became longer, moving further away from that blue box, which wasn't so good. Many PEP breaths that were previously in the box were now too long. Almost double were now longer than recommended. So overall, there was actually a reduction in the number of treatments that were in the blue box. And there was no impact on breath pressure for PEP. So the same games had the same effect, but different outcomes for the two devices. And this was not always beneficial. So in summary, Project Physio has provided an insight into how children and young people do ACTs and how in future we can aim to reduce the burden of treatments. We recorded 5 million ACT treatment breaths to understand treatment quantity and quality and the impact of gaming. The quality of ACT treatment is important to be able to understand the clinical benefits. A relatively simple sensor allowed us to get novel insight into what people are doing each day to better guide quality treatments, and only 21% of the treatments we recorded met guidelines. We ask people with CF to do these treatments every day, but we and they have been blind to what they're actually doing. As for the sensor-driven games, breath control games can change people's airway clearance techniques. However, not always in the way that we want. So we hope these data can help with future game designs. The mechanics must consider the specific impacts of gaming on breath profiles in relation to the desired improvement in technique. And considering the type of device people are using and what their baseline profiles are is vital to make things better. Project Physio was a remarkable team of over 100 people, some of whom are here, and it was led by Professor Eleanor Main at the UCL, University College London. But we couldn't have done any of this without the children and young people and their families who contributed to the design of the study and also shared their precious data with us. Thank you.
Thank you so much. That's so interesting. One of the questions from the app, did you find a difference in quality of breath with age?
We tended to find as they got older, their the younger children tend to have higher pressures, and the older children tended to, I don't know, maybe they weren't as interested in doing it, so they were a bit less enthusiastic.
And this really was more of like a proof of concept. So what's next?
So obviously now we know about the blue box. Physio 2 will hopefully develop a way where we can encourage people with feedback to do clinically effective treatments. So to be able to provide people with feedback that they need, that clinicians need, to make sure they're not wasting their time.
And would this be expanded to an older patient population
Yeah,
at that time?
definitely. And we would like to include adults as well in the future.
Are there any, oh, here we go.
Thanks for your presentation. You kind of just answered that, but I was like, looking at your presentation, I was like, I feel like the value is like almost like a biofeedback device that we can utilize with every patient. Because I'm like thinking, even if I had this in the hospital and we have the patients and they're training for a period of time, that they could get that breath length down. So is that something that's marketable, or how expensive is it? How would you get something like that was, I guess, my question.
It's a very good question. Yeah, and I think we're giving out these devices without the right insight into the important bit. It's do your 100 breaths, that's great, but how they're doing their breaths is what we need to know. So hopefully we will develop something in the future that can provide those insights. Just giving people a manometer and seeing their pressure isn't enough. It's important to see the whole breath profile.
Yeah, it would work perfectly like a biofeedback for
Yeah,
that.
exactly.
And also good for RTs, PTs, physios, because we're giving them that. Unless you always have the manometer on it, you're not even sure exactly that you're getting the quality. But I love this. I think this is fantastic.
But yeah, that's definitely the future, will be giving some kind of biofeedback so they can see maybe a bit like pheno, maybe where you've got a target range, is your breath within that range or something along those lines, as opposed to just the way we design these games.
Thank you so much for being here with us today. We appreciate it. Thank you, everyone, for being here today. We appreciate your attendance.